Welcome to the High Risk Pregnancy Training Academy, where ANMs, medical officers, and specialists come together to learn about high-risk pregnancy conditions, share experiences, and work together to ensure the best health outcomes for mothers and babies. Today, our expert doctors are talking about the identification, management, and treatment of hypertension in pregnancy.
Hello everyone, I am Dr. Karishma Tharyani, consultant obstetrician and gynecologist practicing in New Delhi. Today, we shall be talking about hypertension in pregnancy. As we all know, hypertension is one of the most commonly encountered high-risk medical disorders in pregnancy. In India, it is second only to anemia. It is one of the most dreaded high-risk condition for any clinician caring for high-risk pregnant women. So today, we have with us Dr. Poonam Tara. Ma'am is a senior consultant, maternal and fetal health, practicing at CFMC New Delhi. Welcome, Dr. Poonam.
Thank you, Karishma. Yes, it is indeed a very, very important topic. Hypertension in pregnancy is one of the most common medical disorders in pregnancy, second only to anemia. Nearly 8 to 10% of women can have hypertension in pregnancy. So it's very important to be able to diagnose people or women who are at high risk for this condition, and if possible to prevent it by giving aspirin 150 milligram at bedtime before 16 weeks or calcium later on to the extent of 2 grams per day, which can help in preventing, provided we understand that these women are high risk for this condition to happen. And once it is developed, it's very important to refer to the right place, manage it accordingly, and save the lives of women and their babies.
Dr. Poonam, what is hypertension in pregnancy?
So hypertension in pregnancy is when the blood pressure gets more than 140 systolic and 90 diastolic. This has to be coupled with a urine test as well whenever the patient comes for the antenatal visit to be able to make sure that it is only hypertension, because hypertension can present either before 20 weeks, which becomes a chronic hypertension, or it can come after 20 weeks, which is what is called as a gestational hypertension. There is also an element of proteins coming into it, where the whole condition becomes preeclampsia. And the fourth of it is when the chronic hypertension is superimposed on preeclampsia. So we have to decide what it is, because the implications on the pregnancy would depend on what the classification would be.
Basically, either a woman can have pre-existing hypertension or she can develop hypertension during pregnancy.
That's right, yes.
So what happens in pregnancy that a normotensive woman suddenly develops hypertension? Why does it happen? And how does it impact the pregnancy?
So in pregnancy, the placenta happens to be the third most important factor, along with the maternal and the fetus. In cases where the blood pressure becomes a problem, there is an impaired placentation, which means that the placenta does not develop as good as what it should be. And this is because of multiple reasons, the commonest being that the spiral arteries don't work very well. Okay, so this also causes vasoconstriction, which means the blood vessels become constricted, and therefore the element of hypertension comes in. In the further eventuality, the entire organs, which include the liver, the kidneys, even the brain, can get affected, which is how the preeclampsia can come in. So that's how and why this problem happens. The impaired placentation is much more when the preeclampsia sets in before 34 weeks. The later part of the preeclampsia happens to be more because of the vasoconstriction or the element at the level of the cells inside the blood vessels.
Dr. Poonam, how does hypertension affect the mother and the baby?
So hypertension, the preeclampsia actually, which is a combination of hypertension and proteins in the urine, is because of the impairment of the placenta. So the placental implantation or the blood vessels which should be growing well in the placenta doesn't happen that well. So this results into maternal complications and the fetal complications. The maternal complications could be any organs that get affected, for example, the liver, the kidneys, the brain. Now, the most dreadful of the complications is when the woman starts throwing a fit, which is called as a convulsion, or has some kind of a cerebrovascular accidents like stroke. With respect to the liver problems, the liver function starts increasing, and anything above, twice the above, the normal levels is quite significant, as also the increase in the creatinine levels and the kidney functions getting raised. So that's the reason why the proteins can get excreted out of the urine, causing problems. Now, because there is an impaired placentation, the baby also gets affected. So the baby's weight becomes less. That's called as a fetal growth restriction. And it also means that the baby may have to come out early, which is the preterm birth, or it can also lead to intrauterine death of the baby. So these are the complications which can happen with preeclampsia. And obviously, the higher the blood pressure, the patient may have symptoms associated with it, which is like a severe headache, blurring of vision, can have epigastric pain, can have a feeling of swelling all over the body, especially the non-dependent areas. So if the patient says that the ring that she's wearing is quite tight, it is very significant, because pedal edema, although is there, but it is also present normally in 80% of normal women. So anything non-dependent should make the ANMs or the doctors aware that there could be an impending hypertension problems which happens, and therefore with every antenatal visits, the hypertension has to be measured properly. The blood pressure has to be measured properly to unravel the hypertension, as also the dipstick in the urine, to make sure that it's not more than 2+ proteins, which will classify as proteinuria. So a combination of high blood pressure, which is 140/90, with proteinuria, with any complications which we've just said, the symptoms, along with the fetal problems, should make us aware that this is a preeclampsia which is happening, and these kind of women should be triaged quickly to the medical officers and to the tertiary referral centers for booking and further delivery.
So, ma'am, when we have to classify a patient, is it possible doing this at the grassroots level, where the ANMs and the medical officers do not have sophisticated diagnostic techniques? Can you tell us just some summary points in history, things to look for in examination, and which are the women in whom the grassroots level healthcare worker should suspect that this woman can develop hypertension later on in pregnancy?
Yes, of course. So to answer your question, history taking is a very, very important factor. So just taking the normal history, the present history, the time, say for example, the patient is less than 20 years or the patient is more than 35 years, first pregnancy, or if she's had a previous pregnancy which has had hypertension issues or preeclampsia, or in her family, her sister, elder sister or mother has had preeclampsia, or the patient has some kind of syndromes like the antiphospholipid syndromes or diabetes, which is very common, or even the chronic hypertension, so any kidney-related diseases. So all these things should make the ANM be aware that this is a potential candidate who is likely to get other issues which can lead to preeclampsia and, unfortunately to eclampsia. So these are the women which needs further help and referral. So the history taking has to be very meticulous, not just the present history, but also the past history, the medical history, even the history of the, the ambience where she is, the family is important.
True. And ma'am, some summary points for examination.
So once the history taking is complete, the next step is to do a blood pressure done in the right way, with the right cuff. And that has to be documented. So every time the ANM goes to visit a lady, it has to be documented, the blood pressure, and preferably a urine test has to be done at the spot for the proteinuria, which is a dipstick test, to be able to say whether it's a trace or 1+ or 2+ of protein, and anything above or equal to 2+ should make the patient aware, or the ANM aware, that this is a likely potential candidate for problems to happen. And once we've done the blood pressure, the weight becomes an important thing, because weight if the patient is increasing weight regularly, for example, in a week's time, she's gained 500 grams more, that should also make the lady, the ANM, be aware that, again, this is a problem which may happen, because in preeclampsia, the fluid gets retained in the third spaces, and therefore the patient appears to be swollen up. So these are the few things which are important. And then coming to the symptoms of the patient has to be discussed, and if need be, to be asked straight away. Do you complain, or do you have, or have you ever thought about headaches you have, which is not getting better with paracetamol, or you have any problems with the visual eye problems where the blurring is happening, or some photophobia is happening, plus any pain in your abdomen, or do you have any episodes of vomiting? So these kind of things should make the ANM aware, and together they should triage the patient more to the MOs, to the medical officers or the tertiary centers.
Dr. Poonam, you've beautifully highlighted the points on history and examination that all the clinicians and primary level healthcare workers should keep in mind. But sometimes what happens is that an ANM may come across a patient who was normotensive in the initial part of her pregnancy, and she suddenly presents with high blood pressure. What should the ANM do if such a situation arises?
If the ANM goes to the lady and finds out that the BP is more than 160, 110, or the urine proteins are more than 2 pluses, or if the patient is complaining of the symptoms that we highlighted on, like the severe headache, epigastric pain, visual disturbances, the ANM should think about referring at the earliest possible. Before referring, she has to be sure that the patient is given the medicines, which is the antihypertensive, which can be given in the form of nifedipine 10 milligram per orally, which means taken with water and not to be kept underneath the tongue. Or she can use labetalol 200 milligram stat, and then start making the family aware of the problem and how much of a problem it is, because the family members need to be aware that there is a problem and this patient or the women needs to go to a higher center and perhaps to stay there for a little longer. So once the tablet is given, once the blood pressure has been done twice and documented, proteinuria has been done, this has to be put in the records, the timing of giving the antihypertension tablets, as also the counseling. And it would be good if the ANM can tell the patient where to go, and the center also is aware that such and such patient is coming to them with this problem. I think once that is looked after, the ANM has done a really good job.
Very well put, Dr. Poonam. So for the ease of our audience, an ANM has to refer all women with hypertension to a higher center. If the ANM finds that any woman has come with very high blood pressure, that is a blood pressure of more than 160 by 110, or a woman presents with a danger signs such as headache, vomiting, epigastric pain, or blurring of vision, in such cases, the ANM should first stabilize the patient by giving her antihypertensives and only the IM dose or the IM part of the loading dose of magnesium sulfate. Whereas a medical officer will refer such a woman after giving the full dose of magnesium sulfate. Ma'am, could you please highlight how is an ANM or a medical officer supposed to manage a woman if in an emergency she throws a fit there or goes into eclampsia, so to say?
Okay. ANM can give the antihypertensives in the form of nifedipine or labetalol, as also the intramuscular magnesium sulfate as highlighted before as per the protocols. The medical officer also should be doing the same, the antihypertensives along with the magnesium sulfate, either intramuscularly or IV. But the most important thing is to keep this position in the position of the women in the left lateral position. Make sure the airway, breathing, circulation is good. So the ABC has to be followed. IV line should be inserted, and effort should be made that not more than 70 ml per hour of the fluid is going in, which is in the form of Ringer's lactate. Okay, and oxygen can be given. Magnesium sulfate already is a first line of treatment when such a fit is being thrown. After this, fetal heart rate, once the woman is is stabilized, then the next step is to look into the baby's heart rate and make sure the baby is okay. In the interim, catheterization needs to be done because the urine output has to be measured hourly. So while this is happening, there has to be a communication with the tertiary center for the referral as well. So important thing after giving magnesium sulfate is that we have to monitor the toxicity of magnesium sulfate, which is by monitoring the respiratory rate. If it is less than 16, it becomes, it's a danger sign, or there is an absence of the knee reflexes or the plantar reflexes, or the urine output becomes less than 30 ml per hour. So whenever such a things happen, there is an antidote to it, which is in the form of calcium gluconate, which can be given as 10 ml of 10% of calcium gluconate over the next 10 minutes. And obviously, this woman needs to be referred to the tertiary center for further management and delivery in the next 12 hours or so.
So like Dr. Poonam has beautifully highlighted all the situations as to when an ANM or a medical officer should refer the woman to a higher center. What we need to remember is that delivery of any high-risk woman, especially a woman suffering from pre-eclampsia or pre-eclampsia with severe features, should only take place in a tertiary level hospital, where there is an availability of an obstetrician, an anesthesiologist and a pediatrician. What is also important is the postpartum care of such women. Dr. Poonam, could you please tell us about the postpartum care of these women? And what all things should an ANM and a medical officer keep in mind?
So once the patient leaves the hospital, it is important to measure the blood pressure regularly. It is important to teach the patient as well as the family members to look for signs of any symptoms which can be life-threatening or can be suggestive of any further complications. ANM should be visiting the pregnant lady once she leaves the hospital, should go and visit in a week's time too, in 3 weeks' time and in 6 weeks' time. And in the interim, she should be in communication with the family members and the women to be able to understand the patient is doing okay. It is also very important that this patient does not get pregnant again. So the postpartum contraceptive advice has to be given, and follow-up visits have to be planned accordingly.
A woman with pre-eclampsia who's been discharged from the hospital needs to take adequate rest while taking care of her baby. Her blood pressure should be routinely monitored by the ANM. Family and the patient should be warned about the danger signs.
That's right.
Because complications like eclampsia can also happen in the postpartum period.
Right.
So, in today's session on hypertension in pregnancy, along with Dr. Poonam Tara, we have understood what is hypertension in pregnancy, how and why it impacts the life of a mother and the fetus, what are the complications that it can cause, and how by prompt diagnosis and proper management by starting antihypertensives on time, we can actually prevent these complications. She has beautifully explained to us why these women should deliver at a tertiary level setup where there is a specialist available all the time, and the need for proper postpartum care. By following these little things, we can actually make a difference in the life of the mother and the fetus affected by hypertension in pregnancy. So I would like to wholeheartedly thank Dr. Poonam Tara for being with us today. Thank you, Dr. Poonam.
Thank you, Karishma.
That brings us to the end of this training session on identification, management, and treatment of hypertension in pregnancy. Have a look through the high-risk pregnancy management booklet for more details about management of high-risk pregnancy conditions.